going to pick up with stroke, kind of where we left off last night. Now tonight we've got 3 more chapters after this. So we are going to, you better just like grab on, because this train is leaving the station fast. It's a super train. So there's going to be a lot of reading you're going to be doing on your own this weekend, right? Everybody's hanging around reading, right? Yeah.
I read the chapters before, the 3 chapters today.
Excellent.
I was happy.
I think that's great. Okay, let's look at what a stroke is. Stroke is going to be death or injury of brain tissue caused by oxygen deprivation. So for whatever reason, oxygen is a short supply in the brain, usually due to a blockage in one of the arteries or else like an aneurysm that burst, most common causes. So, causes of strokes. All right, well, we got 2 types of strokes. We have an ischemic stroke. Remember I talked to you about the word ischemia the other day? Ischemia means there's the tissue is injured. It hasn't died yet, it's just injured. So usually if you can get it while it's still in the ischemic state, it can be fixed. The word specifically ischemic. But we're talking about an ischemic stroke versus a hemorrhagic stroke. With an ischemic stroke, there's a blockage in the artery so that the oxygen in blood is not able to get past that point. 80% of strokes are ischemic strokes. That means that the overwhelming majority of your strokes that you're going to encounter are going to be due to a blockage in the artery in the brain. The other kind is going to be a hemorrhagic stroke. What does that sound like? Hemorrhagic means what?
Bleeding.
Bleeding. That's right. So with a hemorrhagic stroke, you're going to have bleeding in the brain. And this is going to result from an aneurysm that has busted. We saw some photos of that the other night, remember? So our ischemic strokes are blockages. Our hemorrhagic strokes are bleeds. Which of these 2 do you think, or which one of these is going to be worse? Why? Yeah, was that bleeds, that blood is going to fill the brain and put pressure on all the tissues of the brain, and it's very difficult to stop a bleed in the brain. So these are much, much worse. In fact, the majority of your permanent damage from an ischemic stroke, most patients may live with some kind of disability, but they may live for 20 years or more after a stroke. Whereas the majority of your hemorrhagic strokes die within a matter of hours to, they may live for a couple of days. So it's very unusual for someone to survive a hemorrhagic stroke. So we're going to be looking at these 2. The signs and symptoms are a little bit different. Of course, you would expect that when you see, the different causes. Now, so a stroke is either a blockage or a bleeding, right? And we're going to be looking at the signs and symptoms of those. But we're also going to look at what a TIA is. A TIA is a transient ischemic attack. So by ischemic, we mean what? It's a transient blockage, right? There's it's a temporary, where am I moving this thing? A temporary decrease or stoppage of the blood flow to an area of the brain. That's a TIA. So transient also means like temporary. With the TIA, we have small clots that block the circulation. And what happens here is the body has means to break up a clot. That's one of the things that we will do naturally. So you'll get a small clot in there, and then the body does what it's supposed to do, and it'll dissolve that clot if we're fortunate. So with the TIA, it may cause symptoms for maybe 2 or 3 minutes, up to 10 minutes, 15, 20 minutes. But a TIA will resolve within 24 hours. That's why they call it transient, because it will go away. It comes and goes. So this is kind of interesting because you can see a patient that has all the signs and symptoms of a stroke. I mean, they can't move their left side of their body. Their speech is garbled, their everything. Their pupils are unequal, and you're going, holy cow, he's having a stroke. 15 minutes later, you're on your way to the hospital, and all of a sudden they're going, hey, I'm good now. Let's go home. And you're going, yes, I've saved him. But what happened is that clot has cleared. The body's cleared that. So TIAs are good in that they go away, but they also signal that a major stroke is probably on the way. If you're having these small clots, that means you're looking for the big one coming behind it. In fact, I think it's 1/3 of people that have a TIA at any given time will go on to have a full stroke within 30 days. So it's significant. So TIAs, while it's nice that they go away, they are a precursor to something really bad. So they're going to cause signs and symptoms exactly like a stroke. You're not going to be able to tell the difference. I mean, no matter how good you are, how many you've seen, you can't tell the difference because it really is a stroke, only it's not permanent. Does that make sense? So the symptoms resolve when the clot breaks up. I mentioned a complete resolution within 24 hours. Usually much, much sooner. Within minutes is what we usually see. Somebody calls 911, they've got paralysis, garbled speech, whatever it is, and sometimes by the time we get there it's cleared up. But very frequently you'll be en route to the hospital with them and it just clears up spontaneously. It's like, yes, I love that. Let's look at the signs and symptoms of stroke. Have y'all seen that ad that's running on television about, or it's on the radio, because I don't watch TV. On the radio it says, I'm having a stroke. And then the other partner's saying to him, well, you're acting kind of funny. And then the voice is going, I'm having a stroke. Y'all not seen that or heard? No? Well, anyway, the point is that some people, as friends and family, we may not recognize that they're having a stroke. They may not have any speech after they've had a stroke. They can't talk. And you're saying, well, what's wrong with you? Why aren't you talking to me? And who thinks stroke? Because stroke has a lot of different signs and symptoms. Depending on where that clot is in the brain will dictate what type of signs and symptoms they have. If it's very close to the midline of the brain, you may have bilateral signs and symptoms. Usually we think of a stroke. What's the first thing you think of when you think somebody's had a stroke? Paralysis on one side or the other. If it's on the midline, it may actually have paralysis on both sides. It could cause hearing deficits, vision problems, without any deficits on one side or the other. No weak areas, no seizures. It's just an auditory issue or a they can't see, they can't hear, something like that. That kind of disturbance. So yeah, most people think about a weakness on one side or the other, and that is going to be the most common sign that you're going to see when they have an acute onset of weakness. We call that hemiparesis. One-sided weakness or paralysis, just really depends. Now, a severe headache, what's the most common cause of stroke? What is going to be the risk factor that's most commonly associated with stroke? High blood pressure, hypertension. So people that get hypertension, who are hypertensive, it's not uncommon for them to have headaches. What is uncommon is that very severe headache that's the worst headache you've ever felt in your life. When a patient tells you that they have the worst headache they've ever felt in their life, that should kind of start little bells off for you. The most common sign or symptom associated with a hemorrhage, a hemorrhagic stroke, is going to be a severe headache. So if you have a patient say they've got weakness on one side or the other, but they say it's the worst headache they've ever had in their life, then you're going to be concerned for a bleed. Not that our treatment is going to vary. It's just a little scarier because you know that the treatment is not going to be there for them. Other signs and symptoms, it may just be an alteration in mental status where they're just very confused. When you think about a head injury is a result of what? Trauma of some sort. Well, a stroke really is a head injury without the trauma. It's going to present just like a head injury does. If you have swelling in the brain, if you've got bleeding in the brain, then you're going to have symptoms of a stroke. So it would not be uncommon for them to be very confused. They may feel dizzy. Patients that have this type of insult to the brain, would you expect seizure activity? Sure. Your stroke patients very commonly seize. They may report numbness, weakness, paralysis. Most typically, it's going to be on one side of the body or the other. That is going to be your dead giveaway, usually, that you're looking at a stroke. And we talked about hypoglycemia the other day, right? I want to make a point to you that hypoglycemia can have the same effect on you as a stroke does. And I've had patients that they present just like they're having a stroke. They have, right-sided weakness. They have garbled speech. They're very confused. They seize. And it's hypoglycemia and it's not a stroke. So it's very important that if you have stroke symptoms that you check a blood sugar. So remember I mentioned the other day that with all your medical patients, you just need to get in the habit of checking the blood sugar. It's just that important. Another sign of stroke is also something we see with seizure. So they may have loss of bowel or bladder control. What do we call that? Do what? Incontinence. You can have incontinence of urine or of bowel. So incontinence is the word that we're looking for. You want me to spell that? We got it. Yeah, spell it. Let me write it. I-N-C-O-N, continence. Does that look right? Yeah, that's right. Incontinence. And that's something nobody wants to fake. You know, you might have a guy that'll fake a seizure, but he's not going to wet himself. You can take that one to the bank. Impaired vision, I mentioned that a minute ago too. Hypertension, most common cause of a stroke, most common risk factor, so they may very likely be hypertensive. They may have difficult respirations depending on where that stroke occurred. If it's low, close to the brainstem, or if they've had bleeding over a period of time that's putting pressure on the brainstem, then they may have difficult respirations, even snoring respirations. They may be unconscious. Nausea and vomiting, common side effect. Seizures, unequal pupils. Always check the pupils. It's just a habit you get. Just check them on everybody. Your trauma patients, your medical patients. Just like you get a pulse oximeter reading, you get vital signs, you need to check their pupils. Headache. Loss of vision in one eye, that would be just like hemiparesis. Unconsciousness. Most of the time your patients are going to be conscious unless they've had a bleed or if they've been down for a while. You know, if somebody comes home and finds grandpa and nobody's seen him since yesterday, then he may be unconscious. Communicating with a stroke patient, it can be challenging. Imagine yourself with your brain working normally and you're locked in your body and you can't talk and you can't move. You're just paralyzed. But your brain's working good. Can you imagine how horrific that would be? I can't even imagine that. You've heard of people that have been put to sleep for surgery or something, but they're really not, they're not pain-free, they're not totally anesthetized. I mean, I've never felt that, but I've heard about it. And they lay there trapped in that body and they can't move, but they feel pain. It's kind of like that. They know very frequently that something bad's happened to them, they just don't know what it is. So try to be as caring and understanding and patient as possible. Aphasia is a general term meaning difficulty in communication. What's the A? A means without. So without communication here. So you may have to be very creative in trying to communicate with your patient. Determine what their weak areas are. They may be able to write, they can't speak. They may have difficulty understanding you. You may have difficulty understanding them. Because communication language occurs in a couple different places in the brain. So they may be able to understand your words and then they try to respond and they can't do it. Or vice versa. You speak to them and they can't make heads or tails out of what you're saying. They know, it's like you're speaking a foreign language to them. So try to be as patient and understanding as possible. Now we're going to use something called the Cincinnati Stroke Scale. And that's going to be an assessment that we would use to do just a very quick rudimentary test of a patient to see if they have the possibility of a stroke. And there are three parts of it. The first part is going to be their smile. So you're going to ask your patient to smile for you. And that's going to show if they have a weak area on one side or the other. So if they can't smile, that's usually a pretty good giveaway. Next, you want to ask them, one thing a comment I want to make, oftentimes your patient doesn't realize that they're not giving you a whole smile because they can't feel the other side. So they give you this, you know, it's me, and only one half of the face is moving, and so you're kind of going, oh crap, not good. Next is going to be what we call pronator drift. I don't know if that's in your book or not. Pronator drift is you have your patient raise their arms up, and they'll either have a total inability to move one arm, or it'll be very weak. Sometimes they can move them both up like this, and then the other one drifts down. That's what we call it pronator drift. So you bring them up, and then it just kind of drifts down. Sometimes you may have to bring your patient's arms up, then let go, and then see if they can hold. Tell them, I want you to hold your arms up. You bring them up, and then one drifts down. It may be slow, or maybe weak, or they may not be able to move it at all. And the third one is speech. So you want to have them repeat something. You know, the quick brown fox. Did y'all ever learn the quick brown fox? No? Okay, the quick brown fox jumped over the, what is it? Lazy dog. You hit all the letters of the alphabet. Never mind. The sky's blue in Cincinnati. Really? It's like the sky's blue in Los Angeles. Don't think so. Have them say something and then see how their speech is. This can be quite terrifying for them because often they'll hear themselves if they garble it or they can't see it. They may not be able to see their facial response, but they know they can't talk. Okay, so once you've done your Cincinnati stroke scale, that Cincinnati stroke assessment, then you want to make sure you document that. And you may check it later on too to see if it's progressing, if it's getting any worse. But our care for our patient is still going to be just like our initial assessment, right? Our primary assessment, it's going to be ABCs, right? That whole thing. So you want to try to calm and reassure your patient because they're going to be terrified. I can tell you I would be terrified. You want to monitor their airway. Depending on if it's a bleed or not, or how bad the stroke is, they may very easily have airway impairment. We mentioned nausea and vomiting, but they may vomit. So you have to be careful how you position these patients. You don't want to restrain your patient in a high Fowler's position while you're moving them on the stretcher, you know, down through the house, and all of a sudden either they go unconscious or they start vomiting all over the place. You know, if they're sitting up like this and they start vomiting, who's going to get it? Y'all get it. Yeah. So you probably want to go ahead and put them in a recumbent position. You know what recumbent is? On their side. And if they have a weak side, one side is weak or paralyzed, you want to lay them on that side to protect it so that their good side is up. So that's how you position them. At most, if you put them in Fowler's, put them in a semi-Fowler's, no more than 30 degrees. So if this is 90 degrees, how much is 30 going to be? Right, a third of that. So they're pretty well laid down where they're not going to tip your stretcher over. They're not going to like vomit all over the place. These might be patients too that if they're having a bleed and it's bleeding quite rapidly, then you're going to get the progression just like you would a head injury, and they may start posturing on you. You know, they may go unconscious and start posturing or start seizing. So you don't want them to be doing that while they're sitting up in a Fowler's position. You'd rather them be laying down. You will put them on oxygen, as we do in any patients with anything serious going on. All right, I already told you that. You want to try to transport them to a stroke center if there's one available. I don't think there's one here. Do y'all have any idea where the closest stroke center is? It's probably Montgomery or Columbus. Did you say?
I'd say
Birmingham. Birmingham, they have such traffic issues. You can probably get to Columbus there quicker. I don't know a whole lot about Columbus, but I think they've got a level 1 trauma center down there. If they have that, they probably have a stroke center too. And this is important because, number one, they have to have access immediately to a CT scan. But something we'll talk about here in just a second. Yeah, it might be on here. Y'all got your little clickers? Let's get it. Determine and document the exact time of onset of symptoms. This is important because with a clot in the brain and ischemic stroke, very frequently we can give them medications to break up that clot. And if we do it within 3 hours of onset of symptoms, they may have a complete and total resolution of their stroke. Is that marvelous? 10 years ago, you couldn't do that. 15 years ago, it wasn't out there. But if you can have a documented time that symptoms began, documented means you know exactly when that stroke began. And you want to, if there's somebody in the house that knows exactly when that started, when you're transporting that patient, you need to take them with you to the hospital because that physician's going to want to talk to that bystander or family member, whoever it is. Why is that important that we have a documented time? Anybody have any thoughts? What medication are we going to give them? What's going to break up a clot? Yeah, I'm not sure what all y'all said. Y'all said. Yeah, we have, they're like blood thinners, they're clot busters. We call them fibrinolytics. They'll break up a clot. Well, can you imagine if your patient had been down for 8 hours? Say they had that stroke at 10 o'clock at night when they were in bed, and somebody finds them at 7 or 8 o'clock the next morning. They've had that clot for 10 hours. The tissue beyond that clot has died. It is like died and gone to heaven. It's not coming back. And if you give them a clot buster, you break up that clot, then that blood that was flowing there now is going into dead tissue, and you're going to have a bleed. You're not just going to have some broken up a clot here. They're going to be bleeding in the brain, and so you're going to kill them. So it was bad enough they had, a stroke, but now you just killed them too. So they had to have that documented time, and that window was 3 hours. So for a stroke, it has to be within 3 hours of onset of symptoms for them to get the clot busters. So you have to be able to document that. I had a patient years ago. We got called to their home in Fairhope at 5:15 in the morning. I don't know what you guys are doing at 5:15 in the morning, but I'm sleeping. So they said it came out as a stroke. So we're thinking, Grandma woke up, Grandpa had a stroke in the bed. Nothing you can do. So we get there, and sure enough, he's out on the floor, and the lights are on. He had fallen out of the bathroom. So that told us he was able to get up, go to the bathroom before he fell out. As we talked to the lady, she said they both had gotten up at 5. Everything was fine. He went in to shave. She went in to make breakfast, and she hears this big crashing sound. So we knew he was fine at 5 o'clock that morning. She told us she looked at the clock. It was 10 after 5 or 5:15. So that's very unusual for that to occur when he woke up and then he had a stroke. Usually he had it 2 o'clock, 3 o'clock, 4 o'clock in the morning. Who knows? So he was able to get clot busters, and he had a complete resolution of his stroke. It was wonderful. So you want to find out that exact time. And you want to document who verified that, who confirmed that. As I said, the physician's going to want to know, because if they give that medication to somebody that's got a 6 or 7 hour clot and it kills the patient, somebody's going to be pretty upset. The clot busters, the term I want you to know is fibrinolytics. A few years back, we just taught thrombolytics because it broke up a thrombus. Fibrinolytics, fibrin is what forms that clot. Remember we talked about how the clot forms, and then fibrin is released, and it puts those little fibers in there to tighten up that clot and increase its strength. So we're going to give them something that actually breaks the clot up, breaks the fibrin tissue. So that's a fibrinolytic. Okay? So now I've got a scar. Y'all ready? Let's see what it says. I'm not going to answer something I just told you. Temporary loss of consciousness. Where's the thing? You know what? Food. Hang on.
I knew it. I'll go ahead and say
Who told you the answer? What's the answer?
B.
B. Syncope. Syncope, that's a funny word, isn't it? It's a temporary loss of consciousness. So this is the way y'all gonna vote for the rest of this one, because I can't get that thing to open. Ta-da! Good job. A quarter of you got it right. I'm not sure which quarter. Okay, dizziness and syncope. This is altered mental status, which is the rest of what we're talking about. If your patient reports that they're dizzy or they've had a temporary loss of consciousness, most of the time it's nothing, but it could indicate something that's very critical or very serious. What might you think that if somebody's dizzy or they're passing out, what would you think of first? Might think of low blood pressure. You've got Granny who's taking too much blood pressure medication, or what else could cause that? They're dehydrated, so they got low circulating blood volume. They stand up too fast, took too much nitro. Yeah, a whole bunch of things. One of the first things I always think about, because I've seen quite a few of these patients, would be cardiac patients. You know, they go into a third-degree heart block or something. Remember we talked about the three impulses, the pacemaker and the heart? You know, if the top two are not working, what's the final one that may be working? The bundle of his. Yeah, what's its default rate? 20 to 40. All of a sudden, you've got a patient, he's got a heart rate of 30. Yeah, then he's going down like a stone, probably. So it can be something serious, or it may be nothing. They just hadn't eaten or something. But it's very difficult for us to know the true origin of it. Now, dizziness means different things to different people. One sensation that people describe as vertigo, and that's where they feel like things are spinning. It doesn't really affect their mental status. They just feel like the room is spinning. Some people will report lightheadedness. That's like the pre-syncopables, just before they pass out. You can just kind of feel yourself going, and you may or may not continue on and pass out. So some people may just report that they're lightheaded. So you'll need to get them to describe that for you. Don't ask them, well, do you feel like you're lightheaded? Do you feel like you're... Say, describe the way you felt. And then you can put it into the block that you need it to go in. Syncope is going to be a brief loss of consciousness with spontaneous recovery. So sometimes if they just sit down or lay down, they'll come right back around very quickly. Some patients may recognize or get that little pre-syncopal if they know they're getting ready to pass out. Causes could be hypovolemic shock. It could be metabolic. What's something metabolic that can cause somebody to pass out or be dizzy? Low blood sugar, yeah, that's right at the top of the list. That can cause that very quickly. Environmental, toxicological, you know, if there's something they're breathing or something they've been exposed to, may cause them that way. Cardiovascular, I mentioned that. Hypovolemic causes, low circulating blood volume is going to be at the top of that list. We see sometimes your elderly patients where they'll stand up and they get dizzy. And it goes beyond just the fact that they may be hypovolemic. But it takes a while. As you get older, your body's not as responsive as it was. For instance, my synapses don't snap as quickly as they used to, probably not as quickly as y'all's do. So it takes me a little while to process something. If you tell me something, it's got to flip around in my brain an extra half a second or second for me to get what you're saying. Whereas when you're 20 years old, those things are just snapping back and forth too fast sometimes. So what you'll get is these older people, and they'll stand up, and the body takes a while for it to vasoconstrict so that you can get that blood pressure up. So they may actually feel dizzy. So we just tell them, don't stand up fast. You know, when you're getting up, sit up in the bed first, swing your legs over, acclimate, and then stand up. So that's a cause of it very frequently. You may have patients that have occult bleeding, which means it's hidden and you can't see it. They could have a GI bleed, for instance. They could have a bleeding ulcer that they're not aware of, which could cause them to be hypovolemic, hypotensive, and they're just not aware of it. Metabolic and structural, you could have patients that have you know, issues in their brain that cause them to have diminished levels of consciousness. They could have a tumor, you know. Inner ear problems, you know, that's our balance thing. So if they have issues there, they could be dizzy, they could have you know, vertigo, something of that sort. Alcohol and drugs can cause you to fade in and out of consciousness, not in a good way. Cardiovascular, bradycardia, tachycardia, any irregularity with the heart, you know, if you decrease your cardiac output for whatever reason, it would not be unusual for you to have a loss of consciousness, or at least have a feeling weak or dizzy. You may have a vasovagal response, which is kind of interesting. If you have a stimulation of the vagus nerve, you may actually pass out. Vasovagal, the vagus nerve innervates our heart. And if something causes it to be stimulated, the vagus nerve is our parasympathetic nervous system nerve, basically. And so it slows the heart rate down, it slows the respiratory rate down, it's just kind of a calming thing. So if something stimulates that or overstimulates that, your patient may pass out. And one of the other things that it does is a function of decreasing your heart rate. It also decreases the contractility of the heart, and it may cause you to pass out because you have decreased cardiac output. So that's never a good thing. There's something we call a commode coronary, so you may hear about that, where, I know you're familiar with that one, where having a bowel movement stimulates the vagus nerve. So you'll get these people, they'll go in, they already have cardiac issues, they sit on the potty, you know, trying to move their bowels, and next thing you know, they pass out, they hit their head on that ceramic bathtub, and they're like DRT. So we would call them commode coronaries. They fall off and then find them in the bathtub or something like that. So it's not uncommon. So when you get called and the patient's in the bathroom, that's the first thing you're going to think of. Okay. Have you seen one of those?
I was trying to figure out what DRT was.
Dead right there. I'm sorry. That's Southern. Okay, sorry about that. Okay, if your patient is dizzy or they've had a syncopal episode, you just want to get a good history to see if it might have some type of cardiac involvement. Ask them if they've ever had, has this ever happened before? Yes. Well, what did the doctor say it was? Or what happened? What did you do about it? You know, did you like go ahead and die after that or what? And get them to describe dizziness, you know, like I mentioned to you. Ask, did you have any warning? Seizures come in a million different flavors. We talked about the tonic-clonic, remember that? But there are a lot of different forms of seizures. So you could have somebody that has a very mild seizure where they actually may just pass out. So you want to see if they had an R or anything before that. When did they start getting dizzy? How long did it last? What position were you in when the episode occurred? You know, if they said, God, I've just been dizzy all afternoon, and then you start asking them, they say, well, yeah, every time I stand up, I get dizzy. Okay. What? Don't stand up? Yeah. But you get that history, and it'll kind of, you can get a differential diagnosis going. Are they on any type of medication? You know, I mentioned, what's the most common cause of seizure? Non-compliant with medication. So you may have somebody that takes medication that they're non-compliant with. Do they have any other symptoms? Are they nauseated? Did you witness any unpleasant sight or experience a strong emotion? You know, that would be, you know, some kind of psychogenic shock, you know, whatever it was, and then get dizzy and pass out. Y'all ever done that? You know, the doctor's about to give you a shot. Yeah, my daughter did that, so don't embarrass me like that. Treatment. Oxygen. Now, if it appears to you to be just a simple case that somebody stood up too fast and got dizzy, I wouldn't call ALS. But if you check their pulse and it's 32, you know, their blood pressure is 90, then yeah, I might call ALS back up. Have them lay down, particularly if you think it's a hypovolemic issue. Make sure they're laid down. You don't want them to, you don't say, well, here, let me walk you out to the stretcher, you know. Let's walk downstairs. No, we don't want to do that. They've already passed out once. If they go down these steps, they go a long way. Not good. Treat any associated injuries if they have fallen as a result of their syncopal episode. Is the seizure a syncopal or syncope a symptom of a larger problem? This is what you're trying to decide. Is it just a simple case? They got dizzy, they stood up too fast, or you know, you're taking pain medications and you don't know what they are. You know, you may kind of get that dizzy. It's okay if we tease you, isn't it? Yeah, okay. Always look for other problems. Cardiac, as I mentioned, might be at the top of the list. I'll look for hypoglycemia. Consider sepsis. If they've had a fever, if they've been sick, look for sepsis. Look where you are. Diabetes is something that you're really going to have to know frontwards and backwards. There's not a whole lot to it, but it's very important that you understand the relationship between insulin and glucose. Hyperglycemia and hypoglycemia, because you're going to get questions about that and you have to understand it. If you have a patient who, say, is a type 1 diabetic, they took their insulin before breakfast, but they had been sick and they were nauseated and they vomit, what's going to happen to them? Their what?
Their sugar intake.
So they have, say they're just really nauseated and they don't vomit, but they took their insulin.
And they didn't eat?
They didn't eat.
Oh, they have vomit. They have low.
So they're going to have low blood sugar. What's going to be their insulin level?
What?
If they took their insulin, So insulin will circulate around searching for glucose. If it doesn't find any glucose, it's just going to go round and round and round. Your cells have to have sugar, so pretty soon it's going to start metabolizing fats and other things that are not good to be metabolized. It's not very efficient. So if you have a patient, say, that should be taking diabetic medication, but they don't know that they're diabetic, and they continue to eat crap all the time, which I'm talking about a lot of carbohydrates and sugars, what do you think their blood sugar is going to be like? It's going to be very high. They're going to be hyperglycemic. If they're hyperglycemic, what are their signs and symptoms going to be?
Thirsty.
Thirsty,
Increased
increased
urination.
urination, hungry. Those are the signs you're going to see. What's their mental status going to be like? Do what?
It'll be good until
Well,
It's going to be good until they become so dehydrated, because our brain requires what? Water, sugar, and oxygen. So if they're hyperglycemic, are they getting sugar to their brain? Let's think about that, what I tell you. If they're hyperglycemic, they got a lot of sugar circulating in the vascular system. Is it going into brain cells? Yeah, that's right. Your brain cells don't require insulin. Sugar can go directly into brain cells. So they shouldn't have an altered mental status due to hyperglycemia just because there's plenty of sugar. But at the point where they become very dehydrated, we're not getting enough water in the cells, now we're going to start seeing altered mental status. So think about the difference between heat exhaustion and heat stroke. Heat stroke occurs as a result of what? Right, a very high body temperature because the body can't cool itself. It can't cool itself because there's no sweat. So sweat because they're dehydrated. So heat stroke comes about because of dehydration. They have sweated it all out. Same thing with your patients that are very hyperglycemic. We're talking about diabetic ketoacidosis. Once you get there, they become dehydrated because they peed it all out, right? Because the body's trying to get rid of all of that sugar. So they're very dehydrated. So what happens to their skin? Hot and dry. It's just like heat stroke. Only there won't be any sweat there, no residual sweat like you get with heat stroke. Because the heat stroke is acute. It doesn't happen over a period of days. Whereas hyperglycemia, what's the time frame there? Yeah, it can be days. Weeks is probably a little bit unusual, but it's going to be a longer time frame. It's not going to be acute like hypoglycemia. We're talking about a matter of minutes, pretty much. Okay. The chief sign of hypoglycemia, oh, we got this in here, is altered mental status. And why is that the case? Because your brain needs glucose. If there's no circulating sugar, it doesn't matter if it goes directly into the brain. There's no sugar to get into the brain. So hypoglycemia, number one, is going to be altered mental status. Seizures, talk about seizures, a lot of reasons for seizures. Could be head injury, spinal injury, low blood sugar. Most common cause of seizures is noncompliance with medication. Know the signs and symptoms of stroke. Know that they can be quite varied. Just because they don't have weakness on one side or the other doesn't mean they didn't have a stroke. It may be all you recognize is when you look at their pupils and they've got a blown pupil, you're going, ooh, you probably have bleed. Make sure you oxygenate them. You may have to bag these patients, particularly your patients who have had a hemorrhagic stroke. There's a good chance they're going to lose consciousness on you and you're going to be bagging them. Make sure you know what the onset of symptoms, the time for onset of symptoms, so that they can consider fibrinolytics. Now in your book, for those of you that already read it, there should be a list in there that describes when fibrinolytics are contraindicated. Because not everybody can have them. If they have a bleeding disorder, they're not getting fibrinolytics because they're going to bleed that much more. If they've had recent surgery, like in the last few weeks, or if they've had fibrinolytics in the last few months, they're not going to get any fibrinolytics. So there's some contraindications for that. But your job, the number one job for you is going to be to determine if it was witnessed, and can somebody identify the time? Syncope, y'all know all that. Now, if you have a patient with altered mental status, you know, you might, probably the first thing I always think of is going to be hypoglycemia. But you got to look for hypoxia, extremely common cause of altered mental status. Before you give oral glucose, you need to make sure that your patient has an adequate mental status, that they can follow instructions, that if you put that in their mouth, they can swallow it, let it absorb, and not choke on it, right? Because sugar is what? Necrotic. Okay, good. Was it that? Was it that? Okay. 62-year-old male is witnessed to have a tonic-clonic seizure. Okay, this is your patient. You get there, and all of a sudden he's doing the whole thing. You find him actively seizing. His skin is pale and moist and slightly cyanotic. What's going to be your immediate treatment? Do what?
Make sure he's not going to knock anything up and hurt himself.
Yeah, make sure that the scene is safe for you. Make sure your patient is safe. What else we got? Make sure your patient is safe. Okay, once they stop seizing, what's going to be your job? Yeah, you're probably going to have to suction that patient. It wouldn't be unlikely that he bit his tongue. So you may have your suction on board there. And you may give blow-by, you may give non-rebreather. It really will depend. There's a good chance that after tonic-clonic seizure, they're going to have a low pulse oximeter reading. So you'll just assess them and treat them like any other patient who's unconscious or has altered mental status. Okay. How did we get there? That thing never did close, did it? Do y'all want to take a 5-minute break while I load this thing up? Okay, I got to load it up anyway, so you can sit there and stare at me, or you can like, I want to try this again.
How are these chapters going to fit nice?
They're not sure.